Hello, everyone, and thank you for joining us for this AGA webinar on impacts of ICD-10. I'm Dr. Larry Kosinski, Chair of the AGA Institute Practice Management and Economics Committee. I'm in private practice and one of the managing partners of the Illinois Gastroenterology Group, a 40-physician single specialty GI group in suburban Chicago. This webinar will go over many of the administrative and clinical changes needed to successfully implement ICD-10. We will discuss the key impacts to strategic business areas, along with the essential steps necessary for a successful implementation. Today I am joined by Rhonda Buckholtz, who is the Vice President of ICD-10 Training for the American Academy of Professional Coders. Rhonda has more than 20 years' experience in healthcare, working in the reimbursement, billing, and coding sectors. She is also an excellent instructor and is responsible for all ICD training and curriculum. We are honored to have her presenting today. As you're all aware, the U.S. Department of Health and Human Services has mandated the replacement of the 30-year-old ICD-9 code set with ICD-10 code sets effective October 1st, 2014. These are the codes used by physicians and other healthcare professionals, facilities, medical coders, and billers to report healthcare diagnoses. To help you ensure smooth transition to ICD-10, the AGA Institute has collaborated with leading organizations to provide you with various resources, including Rhonda and the AAPC, which can be found online at the AGA ICD-10 Resource Center. We're going to get started here, but please note that all questions will be answered at the end of the webinar. So to ask a question, type your question into the question pane. Rhonda, we welcome you to this webinar, and we're all waiting to hear what you have to say. It's all yours.
Thanks, Dr. Kosinski. Thanks, everybody, for joining us today. If you can advance to the next slide, please. This is just a reminder that if you want to record or reuse any of this information, you must have permission of the AAPC. Next slide, please. And so today we're just going to start talking about an overview of changes for ICD-10, where you need to be focused now. We're going to show some changes needed for coders and clinicians. We're going to talk about some documentation changes, what needs to happen for ICD-10, and we're going to go over some case examples. Next slide, please. Now, ICD-10 is set to take effect October 1st of 2014. The International Statistical Classification of Diseases, commonly referred to as ICD, is for all general epidemiological health management purposes and clinical uses. It's published by the World Health Organization, and then we in the United States do our clinical modifications. So we have implemented new versions, and of course now we're going to implement the 10th edition. And so the CM is our clinical modifications in the United States. Each country or each user of ICD makes their own clinical modifications as necessary. Now, for those facilities that bill inpatient facility codes, currently you're using Volume 3 of ICD-9. The transition will also be made to ICD-10 PCS. PCS stands for Procedural Coding Systems. These codes do not take the place of CPT or HCPCS codes. Clinicians need to make sure the documentation is complete enough in order to support the new coding system. Right now, there's approximately 69,000 codes in ICD-10 CM and about 89,000 codes in ICD-10 PCS. This change comes about where we have one date in the industry, this October 1st of 2014, where everyone needs to be ready. Next slide. What you need to be aware of, though, is that not everyone is considered a covered entity under HIPAA. Remember, our code sets are mandated by HIPAA. Workers' compensation plans, auto, and some other liability carriers are not mandated to make the transition to ICD-10 CM. This could quickly become an administrative burden in your practice. If you participate on any panels, you want to make sure that you work early with those vendors to see if they're going to make the transition so you can make informed business decisions on how to move forward. For vendors that don't make the transition, you will have to use dual coding. This means you're still going to be required to submit ICD-9 CM codes to one plan and ICD-10 CM codes to yet another. So think about this, the impact this could actually have to your business transactions. So let's think about this. For example, on October 1st of 2014, Tina suffered a fracture from an auto accident while traveling for work. It took 6 weeks for her workers' comp to determine that they would take responsibility for the claims. The claims have already been submitted to the audio carrier, and after the first-party medical benefits were exhausted, they were submitted to the patient's primary insurance. Now, currently, under I-9, this would simply mean changing the carrier on the claim forms and resubmitting with your notes. Under ICD-10, with this same scenario, the original claims would actually have that have been submitted under ICD-9 would actually have to now be resubmitted under I-10 or vice versa. So the claims will not only require changing the carrier, but also the codes. In a lot of practice management systems, there's a series of security features which locks down certain buckets after a claim's been submitted. Your diagnostic coding, your CPT coding are all in those buckets. And so you want to make sure you work with your vendor, because otherwise you would have the hassle of going back, finding a way to back out that claim and input a new claim without messing up any of your financial data. So we're going to be using dual coding for a long time. I get that question a lot when I'm out in the marketplace, is ICD-9 going away? And no, we don't see it going away right away. It's going to be state by state, carrier by carrier. Next slide. So there might be many of you guys that are listening that are thinking that October of 2014 is still a long time away, but with a transition as large as I-10, you don't want to wait to begin preparing for the implementation. There's probably also many who might be thinking that the deadline is not firm or that extensions are going to be granted. CMS has stated multiple times that the deadline is set and there's going to be no delays. Unlike other transitions we have made in the past, ICD-10 has one caveat that others really did not. If you don't make the transition, you're not going to get paid. There will be no business as usual and no revenue coming into the practice or claims going out the door. Because ICD-10 is not a quick fix, strategic long-term planning is necessary. So let's go ahead and take a look at what will change and the needed revisions in order to accommodate ICD-10 CM. Next slide. In order to properly prepare for ICD-10, we have to begin by taking a look around our practice to determine where the key impacts will be for the transition. You're going to be surprised at just how far-reaching an ICD-10 code is. Administration will have a key number of changes in preparation to do. Any policy or internal procedures that are linked to a diagnosis code, disease management tracking, PQRS, or any other quality measures will need to be addressed. In addition, working with vendors will be essential through the implementation process. Health plan contracts will need to be reviewed to determine possible payment issues and the need to renegotiate any contracts. Also, policy should be checked for timely filing limits, and work should be done with those vendors to determine if extensions can be granted during the transition period when the practice or health plan may experience limitations or difficulties. Vendors need to discuss timelines for implementation and for any possible upgrades that might be needed. Staff training will need to be addressed on any upgrades as well. You need to check vendor contracts for any language on upgrades that are governmental mandates to see if payment is addressed in the contract. If not, during the conversion with the vendor, you will need to determine how much system upgrades might actually cost. At a time when reimbursements are shrinking, budgets will need to be mapped out to determine how the practice will be able to pay for those system upgrades and for education. Basically, everyone in the practice is going to need some type of training on ICD-10. You need to do some type of development of a strategic training plan. The clinical area will be one of the largest impacts during the ICD-10 transition. Think about the enormity. Every single order form, ABN form, payer payment policy, LCD, NCD, and so forth will need to be revised to match the new codes. This will require planning and training of clinical staff. Changes to the superbills may be necessary. Practices will no longer be able to put their top used diagnosis codes on superbills, as most practices will not have enough room to do so with the expansion of the code set. Patient coverages will change with the implementation of ICD-10 CM. It's too soon to tell how, but this will affect prior authorizations, pre-certifications, prescriptions, testing, surgical procedures, and so forth. Physicians will need to focus on the new code set and possible changes to documentation. Documentation will need to be more specific in ICD-10 CM. Documentation needs to include laterality, stages of healing, weeks of pregnancy, episodes of care, just to name a few. With the codes expanding to about 69,000, the changes are guaranteed to impact all of the physicians. It's crucial to work with them early to make sure documentation is compliant enough in 2014 so that coders were actually able to assign an ICD-10 code to the encounter. All your forms are going to need change, such as your orders for x-ray, lab, any diagnostic testing. In addition, nurses will need to make sure that they understand the changes to documentation requirements so that they can better assist providers. As discussed, prior authorizations and such will need to be redeveloped. Changes to ABN forms will require additional education. Labs already face a significant challenge in ICD-9 CM, with so many providers failing to even give enough information currently to support testing that's ordered. ICD-10 CM will bring additional documentation requirements as well as changes in reporting for the labs. All the forms will need to be revised. Next slide. So now that you've seen a glimpse at how large the implementation of ICD-10 is, let's talk about the steps that are needed to get there. Now, we've broken the steps down into 9 strategic steps that make ICD-10 transition a little bit more manageable. So step 1, inform. You're going to give practice decision makers a high-level overview of ICD-10 and get the buy-in to begin implementation preparation. Step 2 is assign. We're going to assign teams to oversee the implementation effort. Step 3, assess. We're going to look at all areas of the practice and determine what has to change. Step 4 is plan. And that's where we're going to do our planning stages of ICD-10 implementation. Step 6, we're going to prepare. We're going to make changes for ICD-10 and we're going to start to move forward. Step 6 is train, and we're going to make sure that we train all changes to all of our staff for ICD-10. Step 7 is one of the most important steps that you want to make sure that you don't miss, and that's test all changes for ICD-10 prior to implementation. You want to work with all of your vendors and make sure you get on the testing schedule. Step 8, that's where you implement. We go live. Hopefully everybody's ready October 1st of 2014. We're monitoring our progress. We're going back and doing reviews to make sure that we're compliant and we're going live. In step 9, no program is ever complete unless you evaluate the results. So we're going to go on and continue to do monitoring, and we're going to make sure that we're getting paid. We're going to run the reports and make sure that our claims are going out the door and that we're still in compliance with all of the new policies coming out by the health plan. Next slide, please. So you want to make sure you work with all of your vendors now, such as your EMR, your practice management, your billing companies and clearinghouses, as well as all of the health plans that you're contracted with. ICD-10 transition will be largely vendor dependent for many items, and it's important to work early on to make sure that they'll be on track for implementation. Many of your own policies and procedures will not be able to be revised until you know what's being done on their side. So check and see if you're going to be able to, if you're going to need any hardware or software upgrades. Will your systems be able to support the dual coding? What about testing to make sure any changes that are made work? Our budgets are going to be really important. How will your business function if revenues stop or delayed? You want to make sure to have a backup plan to cover any short-term expenses. Remember, when developing your budget, you will need to plan for education. Every single person is going to need some level of education for ICD-10 implementation. Next slide. We know that for clinicians, the clinical documentation is going to need to adhere to a higher level of specificity that's found in the ICD-10 code set. We hear significant feedback out in the marketplace where the use of unspecified codes may cause revenue issues. We want to make sure that we steer the physicians away from the use of unspecified codes whenever possible. There's simple ways that we can do that, and I'll show you when we get into the case examples. There are some new concepts that are captured in ICD-10 CM. Even though clinically they were relevant, they weren't required to be documented for coding in ICD-9 CM. So we're looking at laterality, trimesters that are built into the codes, and weeks in pregnancy, and stages of healing, among many other items that we're going to find with combination codes and those types of things as we go down through the learning process. Next slide, please. We know that there's going to be productivity issues. For our coders, everyone has to start back at the beginning. And this is actually what we found that has frustrated the coders the most. They're so used to just opening the ICD-9 book or knowing what codes they're using because they've got them memorized and it's been easy that many have forgotten how to use the index or the code lookup process. We've got to start back at the beginning, which slows us down. We've got to make sure that they get the right amount of training so that they can speed up and so that it doesn't cost a lot of delays in your claim submission. It's going to take time to become familiar with the books, the index lookup, the instructional notes, those types of things. And the code descriptors in ICD-10 are long and very in-depth, and so they'll take a longer time to read and assign, especially if you're using an encoder or your EMR, those types of things. So those are all things that you need to keep in mind for productivity issues for coders. If coders get training too early before they start actively using the codes, chances are that they won't be able to retain all of the information. If you have a coder that's planning to get training in the near future, you want to make sure that they continue to use the codes and to work on them on a weekly basis so that they don't lose the skills that they acquired. For clinicians, we know that additional documentation will be necessary. We've seen this with a study that we recently released where we had the results of 20,000 audits that we did to see if physicians were ready for the ICD-10 transition. What we found as an overall average is that about 65% of the time there's not enough documentation to assign the most specific code in ICD-10-CM. We know that additional documentation is necessary. Those newer concepts that we're going to talk about here in a little bit are going to take some time to incorporate. And of course, even a physician that's coding out of their EMR, those longer code descriptors will take time to become familiar with and to assign in the EMR. So you want to keep that in mind as you're moving forward with your training. Next slide. There's some critical concepts in ICD-10 that you need to be familiar with. So first and foremost, there's greater specificity found in ICD-10-CM. You'll find combination codes where in ICD-9 it might have taken 2 or 3 codes to assign one clinical condition for a patient, where in that combination code in ICD-10, one code will actually capture those clinical conditions. There's some unique coding changes from ICD-9-CM. You'll see the expansion with specificity, greater anatomical specificity, the laterality designations, and those types of things. Looking up injury by the type of wound instead of anatomical locations, all of that. With ICD-10 PCS, we have a completely new coding system. Can't be compared with any other coding system that we have out there right now. The codes are actually built based off of tables. We know that we need to lead providers away from the use of unspecified codes. We want to make sure that we protect the revenue as much as possible. Now, there are legitimate reasons for using unspecified codes. Say it's the first time the patient's being seen and you don't have a definitive diagnosis. That's acceptable. But there's also unacceptable reasons for using an unspecified code. Laterality is a good example of that. We might not be able to tell you the exact anatomical location if we don't have x-ray or if we don't have diagnostic testing done. But for sure we can say whether or not it's the right side or the left side, proximal or distal. That should be documented. So it's looking at those types of things. What we found in ICD-9-CM is sometimes we latch onto the unspecified code even when the clinical documentation and the medical record supplies the type or cause. And we just haven't made the transition. So it's working with physicians and with coders to make sure that once they make that clinical designation, they actually switch to a more specific code. And of course, ICD-10-CM adds 7th character extenders. These 7th character extenders indicate the status of the patient, and they change based on what chapter you're in. Not all codes require a 7th character extender. It depends on what section you're looking at, but that's also a new concept for us in ICD-10-CM. You're also going to find a multitude of instructional notes in ICD-10-CM that you did not find in ICD-9. There are a lot of code additional notes, especially when you get into certain conditions that are contributed with other factors, such as tobacco smoking or alcohol use and those types of things. So you'll see a lot of instructional notes that you need to be familiar with in ICD-10-CM. Next slide, please. So we know one thing, education is going to be a large part of the success. You want to make sure that you plan your education early. This is one of the things that's thrown out very quickly in medical practices because of the lean times that we're in right now with revenue reimbursement. Everyone's going to need some level of training. If you look early, you can find a lot of free methods of training. Look to your societies and those types of things. So you want to plan early. You want to make sure that you train in stages. For coders, we say, let's do our general code set training, and then when it gets closer to the time, do specialty-specific coding that will make them the expert in the industry. For physicians, let's do a round of ICD-10 readiness assessments, which we'll talk about here in a little bit, train them on the clinical documentation concepts, and then do another round of assessments after we've done that baseline in the training and education, and see what's stuck, and then see where we need to go back and do remedial training. We want to make sure that we measure productivity and retention. There's a lot of myths out in the marketplace where they talk about how slow coder productivity is. We've seen that with good, solid education, there are some productivity issues right off the bat, but as the coder works with them, it's not nearly what has been indicated in the marketplace. If you don't plan well, if you don't get educated well, though, that loss of productivity could really hinder your practice. And of course, you want to make sure that you retrain whenever's needed. Again, as I said earlier, no new plan or new change is ever effective until you go back and evaluate the results to make sure that you have the right set of circumstances. Next slide, please. Now, when we talk with physicians and we work with physicians, we don't use the volume of codes to work with them. For sure, a physician doesn't need to know that there's 69,000 codes and we want them to learn a majority of them. The information in ICD-10 CM can actually be broken down into clinical concepts for the conditions. And then once you break down the changes for the coding and how it correlates to the provider's documentation, it's really much easier to process, to digest using those separate concepts. So, when you think about working with a busy physician, the last thing you want to do is walk up to them and say, there's 147 codes for headaches. I need us to sit down and determine how many of these you're going to use. Instead, I can break it down into clinical concepts. Why tell them there's 69,000 codes when there's only about 21 unique documentation concepts into ICD-10? And so even when you break that down even further, most specialties won't even need to know all 21 documentation concepts. So you want to take a look at all of that and review that with the physician. That makes it a much more manageable session. It breaks it down, and it doesn't seem so overwhelming when they're working on a lot of other things. Next slide, please. So you'll see the breakdown of the clinical concepts. A lot of these are recurrent, and you'll see that as you start working through your codes. So you have the type, the temporal factors. Temporal factors are timing. Is it acute, chronic, recurrent, subacute? Caused by or contributing. Symptoms, findings, and manifestations. Localization and laterality. Anatomy, associated with or severity. The episode, remission status, history of the morphology. Complicated by external cause. Activity, place of occurrence, loss of consciousness, substance, number of gestations, outcome of delivery, and BMI. So in order to properly convey those concepts to providers, you want to make sure that you understand what those concepts mean and where they come from. So you'll see that they're recurrent over and over again. So, but when we break these down, and I'll show you when we're going through the case examples, you'll see how you can actually simplify the process for a physician. Next slide. One of the reasons that we're transitioning to ICD-10 is the increased specificity to enable the conditions to be clearly indicated. So you want to make sure that you take care to ensure that the providers and coders understand where the code set is expanded in order to be able to capture that information and to note it on a claim. The clinical concepts of laterality, temporal factors, anatomical location, cause and type, those types of things are key factors. And you'll see this recurrent in documentation concepts as we're working through ICD-10 CM. Next slide, please. A real emphasis needs to be made with physicians to move away from the use of unspecified codes. Now, one tool that the AGA has given you to help is they've taken the most frequently used codes for GI, and they've actually provided a mapping for them that's found on the website. This gives you a nice transition, and it shows you, here's the unspecified code, but here's some much better choices that are available for you now in ICD-10 CM. You want to make sure that you really work with them. Try to push them away. Some of the things that we're hearing out in the marketplace from health plans is that the use of an unspecified code does not guarantee payment. That if you use an unspecified code, they're going to pend your claim. They're going to come out and provide education to you, and then if it was truly an unspecified code, they're going to release your payment. And if not, they're going to train you on that and have you resubmit. That sounds great to get free education. However, that's going to significantly slow down your process of getting paid. So you want to try to avoid those delays and those risks. We've also heard from health plans that say the continued use of an unspecified code will have you get less in revenue. So if you continue to use unspecified code, say you've been treating a patient for a clinical condition for a couple of years, let's say Crohn's disease. So the patient presents with Crohn's disease and you bill unspecified. You've been treating the patient, they're on meds, you're monitoring them for a couple of years, but you still don't know the type, the cause, the location, all of that. That's when they're going to start transitioning away, because their thought process is after a certain amount of time, you should be able to tell the type and cause as we go through. Next slide, please. The best way to help providers transition their documentation to be ICD-10 ready is to perform documentation readiness assessments. So the providers, you can work with them and show them where their risks are. So you run a frequency report that shows the most frequently used codes in ICD-9, and you take a look at the documentation that pertains to those codes. Where are the concepts missing that would help assign a more specific code under ICD-10? A documentation assessment can compare the documentation of the provider today against ICD-10 to show the differences. That's going to give you time to prepare and make any documentation. So run that frequency report, take a look at the big picture, and start your most frequently used codes. Next slide, please. So the report you run by provider will be your working list for education. Take the #1 code for the provider and then run another report looking for patients with that diagnosis. From that report, pull 10 or 15 patients. And then from the documentation present, can you assign an ICD-10 code? If so, are they codes that are comprehensive, or are they the unspecified codes? Then create a report by patient that shows what, if any, ICD-10 code could be assigned, and then what deficiencies, if any, were present. And then you work with the physician on that clinical documentation report. And you're going to continue working down through your frequently run. You can run it by the entire practice, or by the clinic or the facility, or you can run it by provider, whichever is most effective for you in your practice. Next slide. It's important to understand the impact of overutilization of unspecified codes in I-10. We know there's a real increased risk of denials, pending claims, and medical necessity issues due to the use of unspecified code assignment with the new code set. A longer adjudication process due to these increased denials or increased AR due to an increase in pending claims, decrease in productivity and staff time is going to create a lot of problems. It's going to have a heavy impact on the practice finances if you don't plan well for this. Working early and often with your providers to help improve those documentation practices will be a definite benefit as we're moving forward. And as we always do with everything, we're going to go back and reassess that documentation after we've been working in it. So now let's take a look at some case examples and how some general surgery, gastroenterology, is going to change with ICD-10 CM. Next slide, please. So for neoplasms, ICD-10 offers greater specificity in the classification when coding for neoplasms. We need to know the morphology. We need to know if it's malignant, and if so, is it primary or secondary neoplasm that focuses on the treatment, or is it carcinoma in situ? Next slide, please. Is it benign or uncertain behavior, or is it not yet determined and documented as unspecified? What's the anatomical site of the neoplasm? And then, when applicable, the laterality of the neoplasm. Are there any contributing factors such as exposure to environmental tobacco smoke or exposure to tobacco smoke in the perinatal period, history of tobacco use, or occupational? Because you'll find those instructional notes often in these codes. Next slide. Colorectal cancer starts in the lining of the bowel. If left untreated, it can grow into the muscle layers and underneath. Now you can see from this slide how it has increased on the codes for anatomical specificity. So that fourth character in ICD-10 starts to give us that specificity. So you see where you have C18.0 for the malignant neoplasm of the cecum. You see 0.1 for the appendix. Then we have the ascending colon, the hepatic flexure, and so forth. So the one thing that you want to keep in mind is that, especially when you're working with your coders, a lot of times physicians will document in centimeters. And so you want to make sure that you capture that in the coding process and that you know your anatomy so that the correct codes can be assigned. So you can actually see where these go down and how anatomy and the correct documentation is going to be really important when assigning these codes. Next slide, please. For other and benign neoplasm of the colon, such as adenomatous colon polyps, it's coded according to the nature, the type of the neoplasm, and the site of the neoplasm. So you can see we have some examples here for you. D12.6 for inflammatory polyps of the colon. We also have subcategory K51.4 for polyp of the colon that has no further definition, K63.5 for just a polyp of the colon. So you can see there where we have additional as well. Next slide, please. So let's just review a simple clinical example. In this clinical example, the polyp is removed from the descending colon, and the pathology shows the polyp to be benign. The documentation in this case provides both the site and the nature of the neoplasm, which allows for the code D12.4 for the benign neoplasm of the descending colon to be assigned. Next slide, please. For neoplasms of the pancreas, they're assigned to codes from category C25. The location of the neoplasm is essential for proper code assignment, and then the codes are broken down as to the anatomical location. Is it the head of the pancreas, the body, the tail, the pancreatic duct, endocrine pancreas, or other parts of the pancreas? We also have codes for overlapping sites and, of course, the unspecified as well. In ICD-10 CM, there is an instructional note at the beginning of category C25 that also directs us to use an additional code to identify any alcohol abuse and dependence from the category F10. Next slide, please. For example, in this example, you can see we have a 60-year-old female who presents for results of a biopsy of a mass in the head of her pancreas. The results showed a malignancy. We have C25.0 for the malignant neoplasm of the head of the pancreas. Both the nature of the neoplasm, the malignancy, the site, and the location are documented. This level of completeness in the documentation helps us to be able to assign the C25.0. Next slide, please. Let's look at another example. The patient is a 62-year-old male with a long-time alcohol dependence who recently presented with an obstructive jaundice and concerns for pancreatic mass. He underwent an endoscopic ultrasound yesterday revealing a mass in the body of the pancreas. Cytology revealed malignant cells. We have C25.1 for malignant neoplasm of the body of the pancreas and F10.20 for alcohol dependence uncomplicated. The documentation shows that alcohol dependence and it's as a contributing factor in the pancreatic malignancies. The instructional notes tell us to code additionally. Next slide. In ICD-10 CM, the codes for cirrhosis are divided based upon the underlying cause, such as congenital or other diseases. Contributing factors like alcohol, toxins, or other associated findings, such as acidities. When coding for cirrhosis of the liver, the choices include K74.60, unspecified cirrhosis of the liver, K74.69 for other cirrhosis of the liver. That includes cryptogenic cirrhosis, macronodular, micronodular, mixed type, portal cirrhosis, and post-necrotic. We have K70.0 K70.30 for alcoholic cirrhosis of the liver without ascites, and K71.31 for with. We have K71.7 for toxic liver disease with fibrosis and cirrhosis of the liver, and P78.81 for congenital cirrhosis of the liver. We also have a code in the E section, which is E83.11, hereditary hemochromatosis, including pigmentary cirrhosis of the liver. When coding for alcoholic cirrhosis of the liver, there's an instructional note that states to use an additional code to identify the alcohol abuse and dependence. Next slide. Here's another example. We have a 63-year-old man who presents with progressive weakness, abdominal discomfort, and jaundice. He has no history of or risk factors for viral hepatitis, and he has no history of drinking alcohol. The ultrasound showed hepatosplenomegaly and a small amount of ascites. A liver biopsy showed micronodular cirrhosis. In this example, the condition documented is cirrhosis of the liver. We have the type and the contributing factors. And so the documentation supports here K74.69, other cirrhosis of the liver. Next slide, please. In this example, we have a 52-year-old man who presents to the office with new onset jaundice and ascites. He's been a heavy drinker of vodka for 18 years and is dependent. In this example, the cirrhosis of the is documented includes both the contributing factor of the alcohol and the associated finding of ascites, supporting the code K70.31. An additional code is needed to report the alcohol dependence and is reported with F10.20. Next slide. The largest cause of foreign bodies in the esophagus is food impactions. In ICD-10 the codes for foreign body of the esophagus are divided by content and the complication it's causing. So you can see here we have T18.100, unspecified foreign body in the esophagus causing compression of the trachea. We have 1018.108, unspecified foreign body in the esophagus causing other injury. T18.110, gastric contents in the esophagus causing compression of the trachea. T18.118, causing other injury. We have T18.120, food in the esophagus causing compression of the trachea. T18.128, food in the esophagus causing other injury. And then we have T18.190, other foreign object in the esophagus causing compression of trachea, or T18.198, other foreign object in the esophagus causing other injury. So you can see there we have some code expansion moving forward in ICD-10 Next slide. So for example, we have a 68-year-old man who presents to the ED with increasing shortness of breath. The patient was eating dinner when he felt like he had a piece of meat stuck in his throat. He's been coughing, trying to get it unstuck, but they're still there, and now the shortness of breath is getting worse. GI was consulted, and after testing was completed, it was determined that the patient is experiencing compression of his trachea due to food in the esophagus. So in this example, the documentation provides the necessary information. The contents are the object that is the foreign body and the complication of the foreign body that led to. So in order for us to be able to select that specified code. So it helps us to support T18.120, food in the esophagus causing compression of the trachea, initial encounter. Next slide. In ICD-10 the codes for foreign body in the gastrointestinal tract are divided by site, and they include T18.2 for foreign body in the stomach, 0.3 for the small intestine, 0.4 for in the colon, 0.5 for in the anus and rectum, 0.8 for other parts of the alimentary tract, and 0.9 for the unspecified. Next slide, please. Some codes require a seventh character and extender. Most often you're going to see A, D, and S. The seventh character of A is for initial encounter. Now what I always strongly caution everyone is to not latch onto the word initial. Instead, replace the word initial with the word active. A is for active treatment. So examples of active treatment are surgical treatment, emergency department encounters, evaluation and treatments by new physicians. So just don't latch onto that word initial. Make sure that you remember A is for active. Subsequent is for follow-up visits, and then S is for your sequelae or your late effects. Next slide. So if you take it back to the T codes that we talked about, those codes actually require a 7th character extender. So you can see our example here. We have a 2-year-old. He was seen in the ED with abdominal pain. The X-ray films show a button battery located in the stomach. We have 1018.2 XXA, foreign body in the stomach, initial encounter. Now, it's important for me to point out that those 2 X's are called dummy placeholders in ICD-10 CM. Because that 7th character has to remain a 7th character, if the code does not have 6 characters, we have to fill in the blanks with dummy placeholders. The letter X is represented as a dummy placeholder in ICD-10 CM. Next slide, please. It's important to note that codes that describe signs and symptoms are acceptable for reporting purposes if a related definitive diagnosis has not been established or confirmed by the provider. If you do not have a definitive diagnosis, it's perfectly acceptable to code the signs and symptoms. Next slide, please. For the digestive system and abdomen, ICD-10 CM offers greater specificity when coding those signs and symptoms. So for coding for the abdomen, the choices include the symptom or signs such as pain, tenderness, rebound tenderness, swelling, mass and lump, or rigidity, laterality, and then the site, right upper quadrant, left upper quadrant, right lower, left lower, epigastric, periumbilical, and generalized. Here's one more example. A patient visited his general surgeon with complaints about epigastric pain. The physician documents epigastric rebound, abdominal tenderness, and orders testing. You can see here where we have the code R10.826, epigastric rebound abdominal tenderness. Next slide. Teamwork is extremely important for us in ICD-10 implementation. We just went through a ton of information from the beginning points of implementation to how to work with your physicians in some case examples. You want to make sure that you understand the clinical concepts for your practice and for your specialty. Review your EMRs to see what additions can be added to help assist the physician. Can you tweak templates? Make sure that you capture those clinical documentation concepts. You want to make sure that you work with your physicians on their documentation assessments to see where those improvements can be made. And you want to make sure that you provide clear, concise education on any deficiencies that you find or any weaknesses. And then, of course, reevaluate after implementation to make sure that the training has stuck and that you're still in compliance. ICD-10 implementation is doable. It's going to take some time for us to get there and to get it all done. It's not anything that any one person can do by themselves, so you want to make sure that you engage as many resources as you possibly can so that you have a good chance of success of implementing ICD-10. We can open up for questions and answers now.
Okay, thank you, Rhonda, for that informative presentation. It was a lot of material. Before we move on to questions, though, I wanted to let you know that the AGA, in collaboration with Rhonda, has developed an easy-to-use translational set of guidelines for the top 50 most used GI-related diagnosis codes. They're ranked alphabetically by disease and also numerically by ICD-9. And these guides are free to AGA members, but you have to log in to view them and download. Now, we have some time here for questions, and as a reminder, if you have a question, please type it in the question pane, and it'll be answered in turn. If we can't get to all the questions, we will post a Q&A online. Okay, AGA staff, what do we have for questions?
Our first question is, after colonoscopy, can we not bill until we get the pathology reports back due to specificity of polyp removal?
That honestly is going to be a practice decision. You're going to want to work with your health plans and find out how they want it submitted. If there's a chance that you're going to have an unspecified code that's going to cause a revenue delay, then chances are you may need to hold it for pathology. But again, it's going to be a business decision that you need to make after consulting your different health plans that you submit to.
Thank you, Rhonda. Several of you have asked questions about when this presentation will be available, and it will be available on the AGA website probably next week, beginning next week.
No other questions?
Or some more questions?
You better scroll down.
No, if anybody else, if you have any other questions, please type them in.
Okay, we'll give you guys a few minutes. Would have been nice if we should have some music going here or something while we're waiting.
A couple of you have also asked about the mapping of the ICD-9 to the ICD-10, and as Dr. Kosinski noted, they are on the AGA website free to members of the AGA. Under the ICD-10 Center, if you go under Practice and Coding.
And we also are planning a session at DDW for this, so we're really trying to continue to provide support for everybody through the course of this year.
Okay, the next question is, can you suggest the best places for training for staff?
I'm sorry, can you repeat that question, please?
Sure, Rhonda. Can you suggest the best places that staff can get trained?
Well, absolutely. There's a lot of different places that you can get trained depending on what your requirements are for your jobs and your positions. There's a lot of free ways to get trained, such as webinars like this. Of course, AAPC has all sorts of educational, whether it's implementation, general code set, specialty for GI, and those types of things. There's a lot of ways to get trained. For physicians, we offer documentation training, and we break that down by those clinical concepts that are important to the conditions that are used by GI doctors. And so you want to make sure that you take a look around, make sure that it's training that's easily accessible for both the coder and the physician and other staff as you're training. There's lots of ways for you to be able to lighten the load, share in user groups with your vendors, those types of things to start getting ready.
Thank you. The next question is about obtaining authorization for a pre-certification, ICD-9 versus ICD-10, and the actual date of the implementation, which is October 1st. So would you pre-cert with ICD-9-10 or ICD-9-9, let's say on the last day of August or the last day of September? It starts exactly on the 1st, doesn't it?
That's correct. So there's one date for everybody, and that's October 1st of 2014. When you're getting pre-certs prior to the implementation date, you want to check with your vendor to make sure that what you're pre-certing will be effective for either ICD-9 or ICD-10, because sometimes you might have a patient that's scheduled after October 1st of 2014 and something comes up urgently and you've got to take them in. So you want to make sure that your prior authorization is good under most. Most of the health plans that I've worked with have said that they don't consider the actual diagnosis code itself and part of their prior authorization, while some others do. So you want to check with those vendors when you're making them, and I would honestly check 60 to 90 days out when you're doing your prior authorizations to make sure that it's going to be valid for you.
Thank you. The next question is, there's a lot of unspecified and other in the coding. How can we find out what's included in those two definitions?
So this is actually a coding piece of information where a lot of people get confused. Unspecified means you don't know. But when you use the other specified code, it means I know what's wrong with the patient clinically, but there's not another code that's here to describe it. It simply means that there just isn't a better code for it in ICD-10-CM. So you know what's clinically wrong with the patient. There's just not a code available. The use of an unspecified code, and this is what I try to really stress to providers and the coders, is that when you use an unspecified code, what you're really doing is raising your hand to the payer when you submit your claim and saying, I don't know what's wrong with the patient. So, you have to kind of take a look at that, especially when you're trying to obtain reimbursements for medical necessity for higher level of services. So you want to be as clear and concise as you possibly can.
Thank you. The next question is, how do you use the X's in the diagnosis, and when would you need to use them?
So the X's is sometimes a little bit of a difficult concept. So you saw in the codes for the foreign bodies, those codes were actually 4 characters in length. but we needed a 7th character extender to indicate the encounter or the status of the patient. So in those cases, I need to fill in the blanks with those X's. That way, the 7th character remains in the 7th character position. If the 7th character gets moved up in the code loses its meaning and there's no integrity to the code, so when you submit it, it's going to be denied. So not every code requires a 7th character extender. And when you're working in your code books, you'll see where it says check 7th. Just like now, you'll see a check 5th. You'll see a check 7th. You're going to find those 7th character extenders used most often in your injury coding, your obstetrics, some ophthalmology, and in your external clauses and some of those. But you don't see them in every chapter.
Thank you. Someone just made a comment that they listened into a Cigna website webinar, and they gave specifics about for 30 days you won't need a new authorization. So I would suggest that you check with each of your payers on how they're going to handle that.
Absolutely. Yes, absolutely. And just like I mentioned at the beginning of the talk, especially when you're starting now with your implementation process, a lot of us have even signed contracts with our health plans that only allow 60 days for timely filing. If something happens and you can't get a claim out the door, or if for some reason it's not going to your clearinghouse or getting to the health plan, you want to work with all of your health plans. Will they extend that timely filing date? How are their prior authorizations? How are you getting paid, or is there any changes to your contracts or any addendums? So you want to make sure that you work with them early.
Okay. We have time for about 2 more questions. One is, how complicated will ICD-10 be for IBS issues?
So for IBS, you need to know the underlying cause, any contributing factors. Again, you just break it down to those clinical documentation concepts. So if you always remember the anatomical location, the cause or type, any underlying factors or any complications or manifestations, you'll be able to capture the documentations that are necessary for the coding pieces of it.
Again, I've had a couple more questions on what resources are going to be available for this, and I encourage you to please look at the AGA website under the ICD-10 Center and encourage you to have your practitioners, your doctors also review that and start to become familiar with it. Even though we will offer another webinar in June, that's getting awfully close to the October deadline. As Dr. Kosinski said, we are going to have a DDW session on this, and Rhonda will be giving that session. We are at 5 minutes out, so I think we're going to close the session now for questions.
Okay. Well, that was a lot of material. Thank you so much for joining us today in this AGA webinar on the impacts of ICD-10. As we have said, the recording of the session will be available on the AGA website in a couple of weeks. Additionally, you can visit the ICD-10 Resource Center at our AGA website, gesture.org/practice/coding/ICD-10 Center. So, in closing, continue to read AGA eDigest for more information about the transition to ICD-10 and how the AGA is trying to help you to prepare. Thank you, everybody, and have a great weekend.